She has non-rheumatic heart disease, but non-compliance. She presented at 39 weeks of pregnancy with increased fatigue and shortness of breath, and bilateral limb edema, with tachypnic and desaturated. She delivered at the health center, not at the national hospital, at the health center, and then transferred to national hospital due to worsening in symptoms. And then on admission, the echocardiography showed severe rheumatic heart disease, severe mitral stenosis, and a severe pulmonary hypertension. Days into admission, she developed. Sorry. Wise. Okay. Just like days into admission, she developed cardiogenic shock and unfortunately passed away. Here is her echocardiography, showed dilated left atrium, severely dilated left atrium with severely calcified mitral valve and tricuspid regurgitation. Okay. Okay. Second case is a 24 years old female presented at 20 weeks of pregnancy. She also has non-rheumatic heart disease, regularly on penicillin prophylaxis. The first pregnancy was a difficult pregnancy, but then she went on against the advice of her cardiologist and got pregnant the second time. First admission, she complains of increased fatigue and chest discomfort. Echocardiography showed dilated, dilated left atrium and right atrium and severely calcified mitral stenosis. Mean gradient of 12 millimeter mercury. Ejection fraction was okay during first admission, and she was stabilized and discharged 3 days after, and advised to follow up weekly at the outpatient department. However, she again lost follow up after discharge. 8 weeks later, she presented at National Hospital with with worsening of her symptoms, shortness of breath, chest discomfort, and lower limb edema. Echocardiography showed decreased ejection fraction. An MDT team was set, and we currently do not have cath lab or any cardiac thoracic surgeon in the country, so we cannot have any balloon valvuloplasty because it's not an option in the country. Emergency C-section was performed due to worsening of symptoms and fetal distress. Unfortunately, the baby was born premature, only 900 grams, and admitted to NICU, but passed away 10 hours later due to respiratory distress. Mother was stable and discharged 8 days later. I'll just continue talking on the third case. I have 4 cases, and then later on maybe I'll. This is the third case. She's a 27 years old female. She has a history of rheumatic heart disease post mitral valve replacement, mechanical mitral valve in 2016, regularly on warfarin, adjusted between 3 milligrams and 4 milligrams daily, and benzathine penicillin for prophylaxis. This is her first pregnancy. She first presented at outpatient department at the National Hospital, asymptomatic. Echocardiography showed mildly dilated left atrium, but prosthetic valve was okay, and no thrombus of vegetation seen, and ejection fraction was normal. And she know that she could not get pregnant, so when she confirmed that she was pregnant, she stopped warfarin on her by herself. And at that time, we interconsult with obstetric team and started vitamin, folic acid, and to continue with benzathine benzyl penicillin injection, and continue with low molecular weight heparin. However, she lost follow-up after the first outpatient follow-up after getting pregnant. After a few months later, at 36 weeks, she presented again at the cardiac OPD with shortness of breath and chest discomfort. Echocardiography showed mildly dilated LA, left ventricular ejection fraction slightly decreased. An MDT team was set up. Dexamethasone was given for total lung maturity. We also started on low molecular weight heparin and diuretics. She was stabilized after admission. 2 weeks later, during the admission, she developed acute lung edema and ejection fraction reduced. Emergency C-section was done with tubal ligation, and she was stabilized and discharged 7 days after. Her baby was alive. Last case, this is a 35 years old female. She it's a newly diagnosed case when she presented at the National Hospital at 30 weeks of pregnancy. She came in with increased fatigue, chest discomfort, hemoptysis, and shortness of breath. Her echocardiography showed severely dilated, severe mitral stenosis with severe pulmonary hypertension. And she was admitted with treatment. After a course of diuretics, she is stabilized. 2 weeks later, she developed lower abdominal pain and vaginal discharge. The fetal ultrasound was okay. Dexamethasone was given in case of premature labor and to increase fetal lung maturity. And few days later, worsening in abdominal discomfort. She was in active labor, and multidisciplinary team was informed for pregnancy termination. When she reached the OT, she had a vaginal delivery, and then her baby boy only weighed 1.9 kilogram and transferred to an ICU. She was stabilized, observed, and discharged 9 days later. This is her echocardiography on admission. You can see dilated left atrium, severely calcified mitral valve, and there is pleural effusion, pleural and pericardial effusion noted. So the comparison with global and regional literature, rheumatic heart disease are identified as a major contributor to maternal morbidity, mortality, and morbidity. And findings in literature show that rheumatic heart disease is the leading cause of maternal death globally, especially in low and middle income countries. And global variation risks show that low middle income country increases in mortality because there is studies shows in Europe and in North America, more than 600 pregnancy women was admitted in the studies and showed no mortality in maternal mortality in the result. Most of the dominant lesion in the rheumatic heart disease. Mitral stenosis was the main lead lesion causing decompensation in pregnancy. And patient with with rheumatic heart disease increases in pregnancy is at higher risk of heart failure and atrial fibrillation in rheumatic heart disease. And also complex of balancing complex complex of balancing anticoagulation in especially in low and middle income country. It's not universally safe option. It's like we are working on a tightrope. Warfarin, low molecular weight heparin or unfractionated heparin, each carry a risk, challenge, and the risks are magnified in low and middle income country. And limited monitoring, access to multidisciplinary care, poor access to low prophylaxis coverage as well, and lack of team-based care, especially in low and middle income country, increases the highest of mortality and fetal survival. So the challenges in low resources and limited setting, the diagnosis limited and diagnosis capacity, few echocardiography service, lack of integrated cardiobstetric team, restricted access to valve intervention, like a case in my country, inadequate anticoagulation monitoring, and weak primary prevention and poor follow-up, and socioeconomic logistical balance delays care seeking. In conclusion, we all know that rheumatic heart disease is uh, rheumatic heart disease continues to be a leading cause of disease related in maternal deaths in low and middle income countries. Timely intervention can dramatically reduce reduce complication, maternal complication, and perinatal complication. And early detection is essential. Screening programs, access to echocardiography is very essential in women before pregnancy and early in gestation. Pre-pregnancy counseling, which is not really effective in my cases, and prophylaxis is also reduce recurrence of and reduce valve progression. And collaboration, multidisciplinary care is very important as well in managing cases like rheumatic heart disease in pregnancy. And strengthening system and care pathways network is can translate lessons international improvement. Rheumatic heart disease is largely preventable. Early detection, prophylaxis, and coordinated care can save lives. System strengthening, including cardiobstetric, can improve um, um, uh, reduce the mortality in maternal death. That's all. Thank you.